about अथातो ग्रंथि अपचि अर्बुद गलगंड चिकित्सं व्याख्यास्यामः यथोवाच भगवान् धन्वन्तरिः ग्रंथिषु अथ आमेषु विषग्विदध्यातु शोभक्रियां विस्तरशो विजिज्ञः रक्षेद्बलं चापि नरस्य नित्यं तद्रक्षितं व्याधिबलं निहन्ति. In all cases of the Granthi, if the patient comes in the Amavastha, all the protocols of the Shofa, that's a reversal of the Shofa treatment, has to be done. If it is not possible, the next part is about the interventional treatment. So that's the basic issue. But during the whole course of this treatment, the patient's vitality has to be maintained. Because if the patient has a better vital force, the disease can be managed better. So that's the one important thing. So you have to consider the patient's status before you plan the treatment. Now, in case of Vataja Granthi, Tailam Pibet Sarpihi Atho Dvayam Va Tatva Vasam Va Trirutam Vidadhyata Apehi Vata Dashamula Siddham Vedya Chatusneham Atho Dvayam Va. In case of Vataja Granthi, different forms of the Snehana are given. The Snehana could be in the form of either Ghrita or Vasa, or maybe Trivrta, Taila, Vasa, Ghrita also, with the Prasarini or Dashamula as such. So, Taila or Sneha prepared out of this can be given to the patients in Vata Vyadhi or Vataja Granthi. Or the other yogas which are mentioned in case of Vataja Granthi are Himsra Atha Rohini Amrita Tabhangi Shonaka Bilva Aguru Krishna Gandhaha Goji Chapista Sahatala Patriya Grantha Videyo Anila Jay Pralepaha. A lep applied over the Vataja Granthi would be based prepared with these drugs like Himsra Rohini etc. और स्वेद उपनाहान विविधांश कुर्या तथा प्रसिद्धान अपरांश लेपान विदार्य वा पक्वम अपोक्ष पूयम प्रक्षाल्य बिल्व अर्क नरेंद्र जोयैहि तिलैहि सपंचांगुल पत्रमिश्रैहि संशोधयेत् सैंधव संप्रयुक्तैहि शुद्धं व्रणम् अपि उपरोपयेत् तैलेन दास्ना सरलान्वितेन बिलंगयष्टि मधुका अमृताभिः सिद्धेन वा क्षीरसमन्वितेन. So initially you try with the protocols of Lepana and other protocols of the Shofa. If it doesn't yield and if it results in suppuration, if it becomes Pakwa, then Bidarya, it has to be split open and drained. Sushruta has suggested drainage of Vataja Granthi, and once it has to be drained, the inner surface has to be cleaned with them, cleared with the Kashaya of Bilva, Arka, etc. And then the Shodhana has to be done with the Tila and Saindha Kalkas, and then Shodhana, Ropana with the Rasna Sarala Taila etc. as such. Now, Vataja Granthi as such to be identified now is a typical condition where a swelling would present with acute pain, and that acute pain in a case of cystic swelling would occur when there is a hemorrhage. That's Ayamete, Vyakhyate, Eti Tulam, Pratyasile, Krityate, Eti Bhedam. Krishno Amratuhu Bastiri Vatadashta Bhinnasravecha Nilajo Asramacham. A typical condition where any cystic condition may have this kind of an issue, where there could be a sudden bleeding in, and once there is a bleeding in, then the whole condition may become quite painful. And typically in the clinical condition, very frequently we come across this kind of a situation in case of the ovarian cysts. Ovarian cysts, because they are easily movable, there is a possibility of either they are torsion or there is a hemorrhage. In this condition, they become acutely painful. And in such conditions, now the standard protocol would be definitely surgical exploration. We may not be able to, or we may not be justified if you try that conservative treatment of Lepana or so on. So in such conditions, surgical exploration is needed. Even in case of the surface cystic lesions like a thyroid cyst developing hemorrhage, in that condition too, a surgical exploration may be needed. But in superficial cystic conditions, a aspiration may be sufficient, and then followed by, of course, a conservative management may be possible. But a surgical exploration is better. And when we think of surgical exploration in all cystic swellings, the current approach of a removal or complete removal of the membrane, excision of the cyst is a better preparation, better choice than what Sushil has suggested as a simple drainage as such. Anyway, that's about what we have to consider in the current situation. Then Jalokasah Pittakrite Hitastu, Shirodakabhyam Parishetananja, Kakuri Vargasya Shitalani, Pibet Kashayani Sasharkarani, Draksha Rasena Ikshu Rasena Vapi, Churnam Pibet Chapi Haritakinam, Mudhuka Jambu Arjuna Betasanam, Twabhip Pradehan Amjarayeta, Sasharkare Va, Tranashunya Kandehi, Vishyad Abhikshnam Muchilunda Jaiva, Vidaryava Pakum Aposha Priyam Dhavet Kashayan Manaspadianam, Tilehi, Sayesti Madhukehi Vishodcha, Sarpit Prayojam Madhurehi Vipakwam. In case of Pittaja Granthi, the initial treatment would be Raktamokshana with the Jaloka leeches, and then application of the Shitaviri Dravyas Lepa. And if it doesn't yield to all these, then the same treatment protocol that it has to be opened and drained. So Sushruta's approach was always draining and then followed by the cleaning of the wound and then the Shodhana and the Ropana protocols. Now, what we now see as the Pittaja Granthi are those which are infected, acutely infected cysts of any sort. It could be sebaceous cyst which is infected or any other cyst which is infected suddenly, can result in exactly the clinical features of the Pittaja Granthi. That's a Dandashyate, Dhupyati, Jushyate, Papachide, Prajwalati Vachapi, Raktasapito Api, Atava Pitta Bhinasavayustam Vachasam. And quite obviously in that treatment, drainage is necessary. And in an acute infective condition, a excision, whether it is possible or not, depends upon the patient's real situation of the condition. If there is a clear-cut decorated membrane like a sebaceous cyst, excision may be done at the same time. If not, then simple curating may be good enough. So drainage and curating is necessary. Excision or otherwise, that depends upon the patient's condition. And of course, then we may follow the same protocols of the treatment like Shodhana Ropana, maybe with our choice of the drugs, which I may prefer with the Triphala Kwata and Triphala Gugul Gandhakarasayana as internal medicines. हृदयेषु दोषेषु यथा अनुभूव्या ग्रन्थौ विषक्श्लेष्म समुत्थितेतो शून्यस्य विम्लापनमेव कुर्यात् अङ्गुष्ठलोहोपलवेणुदण्डैः विकङ्कता आरगोर काकनन्ती काकादनी तापसवृक्षमूलैः आलयपेयत् पिण्डफल अर्कभार्गी करञ्जकालामधरीश्च विद्वान्नम्. In case of Kaphaja Granthi also, the typical treatment would be same, protocol would be almost similar, but because it's a Kaphaja Granthi and having a harder consistency, Svedana has to be done, Vimlapana and rubbing over the area, so ensure that it is softer, and then the lepa has to be done. Treatment, of course, in the present day situation, again, we consider it could be like a ganglion-like conditions, chronic conditions, and the typical features would be Shitaha, Avivaranaha, Alparujaha, Atikanduhu, Pashanam Samhananopapannaha, Chirabhivriddhischa Kapha Prakopa, Bhinnasarvet, Shukla Ghanam Chapuyam. Typical ganglion-like conditions, and obviously the treatment would be surgical treatment. In such conditions, surgical treatment is suggested. And Sushruta also has suggested a similar treatment, like in case of the Kaphaja Granthi of ganglion-like condition, you do not have to wait till the Pakwa Lakshana, the suppuration has occurred. The process of Pachana is not necessary. Even if it has not become Pakwa, then it can be excised, and this is one exception. In Sushruta, otherwise all surgical interventions are done only when there is a suppuration. And before suppuration, exceptions are, a few of them are the exception where you can do the surgery, and in case of Kaphaja Granthi is one of such exceptions. And the rule is Amarmajatam, Shamam, Prayantam, Apakvameva, Paharet Vidarya, the hair, Sthiteja, Asriji, Siddha Dharma, Sadyakshato, Vidhim Vidatyate. That's exactly the same protocol. You have to make an incision even if it is not suppurated, or you are not supposed to wait till the suppuration occurs. And the only precaution you have to do is the lesion should not be in a vital organ, and during your surgical procedure you are not supposed to injure any vital functions of the body, and hemostasis has to be established after the surgery, and then you treat the wound as usual. Then ya mamsakandeha katinaha bhratyaha tasvesha yogyascha vidhi vidijneha shastrena va apatya subakvam ashu prakshalayet pachyatamehi kashayehi samshodhane hitam च विशोधेत तो क्षारोत्तरैः क्षौद्र गुणप्रगाढैः शुद्धे च तैलं तु अवचारणीयं विडंग पाठा रजनीं पक्वम्. Similarly, non-suppurative conditions like any other polyps or any other hard swellings over the body, that again the protocol is the same, like you have to exercise. Even now, the treatment protocol is the same, that we need to exercise, but we go somewhat one step beyond, like after the excision, the tissue is examined to confirm about the nature of the pathology. If the nature of pathology, like tumor pathology, does exist and which requires a follow-up treatment, you may go for the follow-up treatment. Otherwise, in a benign conditions, you need not do that. So, in all cases of a firm non-suppurative conditions, basically the obvious approach is a surgical excision. Then once you have done the surgical excision, the wound has to be treated. Whether there is a preventive follow-up therapy or not, follow-up treatment or not, that depends upon nature of the pathology. Now, the next is Mersamuthe Kilakalkadibdam Datwa Uparistat Vigunam Patantam Hudasha Taptena Muhu Pramjat Lohena Diman Adahan Vidaya Pralipya Darvim Athalak Lakshaya Pratakteya Swedanam Asikaryam Nipatyava Shastram Apohya Medo Dahet Supakvamta Athava Vidarya Prakshalya Mutrena Tilehi Supisehim Suvastikardi Hritalamishtrehi Sasaindhavehi Shaudra Gazap Pragadhehi Sharottalehi Enam Abhiprashodya Tailam Vidadyat Vikaranja Gunja Vamsha Avalekhe Avalekha Ingudamutra Siddham. In Medoja Granthi, again, the basic treatment is the same, surgical treatment, where you are not supposed to be till the pus has been formed. Before that, to make the surgical procedure easier, or to make the tissue separated easily, to establish a cleavage, you have to apply warmth over the area, make the area warm so that the vascularity increases, and the warming again should not be directly exposing to the heat. The whole area has to be covered with a cloth, and then over that you have to keep a heated metallic rod over the area so that it doesn't really burn the tissue, but warmth occurs and the vascularity of the area increases and helps in making the tissue separated easily. Then or it could be like a application of the lepa of Darvi or Laksha, etc. over the area. Of course, in the present day situation, we may not go for that kind of a protocol where the tissue is separated, gets separated. But in certain conditions, where the tissue separation may be difficult, we may inject a distilled water into the tissue space so that the dissection could be proper. So, in many of such surgical conditions where the tissue separation is difficult, if a blunt dissection may not be possible to do that, then we may inject distilled water into the tissue space, and then it makes the dissection easier. So instead of that warmth which is suggested by Sushruta, in the current surgical protocol, we prefer injection of the distilled water. Of course, the clinical features of Medoja Granthi are same. Sharira Vruddhi Kshaivadhyane Snigdho Mahan Alparuja Atikanduhu Medakrato Gachati Jatrabhine Pinyakasarpi Pradimum Medaha. The similar features as that of the sebaceous cyst, and in case of the sebaceous cyst, it's exactly the same protocol where we excise, and the next part, like the Agnikarma or cautery, may not be required now, because we do ensure that the whole area is excised completely. If there is a possibility of residual lesion left over, which is not so common, you may require the other follow-up treatment like cautery, as mentioned by Sushruta. Then Jimutake Koshavuti Palesha Danti Dravanti Tributa Steba Sarpikritam Hanti Apachim Pravurdham Juda Pravurdam Tadudara Viriam Nirgundi Jati Balihistayutam Jimutakam Makshika Saindhavadyam Abhiprataktam Vamanam Prakadham Dusta Apachishu Uttamam Adishanti Kaidarya Bimbi Karavira Siddham Tailam Hidam Murtha Viretanja Shakhotakasya Surasena Siddham Tailam Hidam Nasya Viretanansho Madhukasarasya Hito Avapide Palani Shigro Hukaramanjareva. In case of the Apache are the lymph nodes, multiple nodes, nodular swellings which occur in the areas of lymphatic aggregation like the neck, axilla, etc. And in such conditions, there is one protocol of prevention, and that prevention would be Vamana. Vamana can be given, and the other way would be Shirovirechana, the Nasya also can be given with the specific drugs as such. then Granthin Amarma Prabhan Apakwan Udhutya Chagnim Vidhita Paschata Ksharayava Api Pratisarayetu Samlikya Shastrena Yatha Upadesham. In case of the Apache, basically another of the exception to our general rule that you are not supposed to wait up to the separation occurring, you have to excise even before it becomes separated. Apakwa itself has to be excised, and then cautery has to be done to the area, or kshara has to be applied, so that there is a complete removal of the tissue, impaired tissue. Now there is another very odd sort of the treatment which is suggested by Sushila. Patients who have the swelling in the lymphatic aggregation area like neck or axilla, Sushila suggests about making an incision in the legs near the calf muscles. Pashnim tadi dve dashachangulani bhitva indrabastim parivartya dhiman budarya matsya andanibhani balibhyaha nishkrishya jalani analam vidadyat agulpakarnat sumlasya jantoh tasya ashthabhagam khudakar vibhajya घोणर्जुवेदः सुरराजबस्तेः हित्वा अक्षिमात्रं तु अपरे वदन्ति. A incision is made over the shin of the leg, and the location of the incision would be Agulfakarnat Sumitra Tasya Ashtabhagam. The whole body length height, the height is measured from the prominence, tibial prominence to the mastoid bone, so that the other possible errors do not come. So measuring the height from a bony point to the bony point, that's from the tibial malleolus to the mastoid bone, and 1/8 of that from the tibial malleolus is the location where the incision could be done. Or it could be 12 angulars from the parshni, that's the calcaneal area, 12 angulars from the parshni. Either it could be one of these options are preferred and incision is made. Now, in the present day situation, I don't know whether there is any such abnormality which can be located or not. After making the incision, you will have to remove some tissue which looks like the eggs of the fish. That's a mass, matted mass would be seen. That's what Sushruta has suggested. As far as with the current knowledge, we do not know whether such a thing is existing or not, or whether such a treatment is possible or not. Another of the options suggested by Sushruta in case of the Apache is Manibandho Parishtatva Kuryat Rekhatrem Vishaka Angulyantariglam Same Apache Namne Vrte Churnasya Kale Prajala Kakaka Godha Ahi Kurma Prabhavam Masindu Dadyatya Tailena Saha Imbudayana Yadbakshate Shlipalinam Tailam Virechanam Dhumam Vadipita Viveccha Nityam Yavamukta Bhuji. Another is making 3 superficial incisions for the bloodletting, and that 3 incisions over the manibandha, over the wrist area at a gap of 1 angula. Now this also is quite difficult to suggest or maybe view from the current science point of view, because current science doesn't know, and whether such a treatment is really useful or not, we do not know. So I just say that I don't have any experience of that. And then once the incision is made, that incision has to be treated with the churna. For the churna, you may use the ashes of burnt animal bodies like Prasalaka Kaga, birds and animals, their body are burnt, and then their masi, that masi is applied, or Ingudi Taila or so on has to be applied over the area. Now, if we consider the Apache as the lymphatic aggregations or lymph nodes which are enlarged, which have the exact similar presentation of what Sushruta has mentioned about the Apache Nidana, Hanmasti Kaksha, Akshaka Bahu Sandhi Manya Galeshu Upachitam Tumedaha, Granthi Stiram Vrittam Adha Ayatam Va Snigdham Kapashcha Alpurjam Karotitam Grantipistu Amalakasti Matrihi Maschanda Jala Pratimehi Tata Anihe Ananya Varnihi Upachiyamanam Taya Prakarshat Apachim Modanti Kanduita Hati Alpurjam Prabhinaha Sravanti Nashyanti Bhavanti Janye Medakapabhyam Kalrogeshaha Sudustaro Varshagadam Bandhi. Now, in case of the cervical lymph nodes or maybe axillary lymph nodes where there is a lesion of lymph nodes, the most difficult part would be the exact diagnosis. Though in majority of the situations it could be tubercular, but not necessarily that it should be tubercular in all conditions. So these nodes, they need to be confirmed. The diagnosis need to be confirmed, and the diagnostic workout is a quite elaborate workout. It may start with the simple imaging studies like ultrasonography, or at the end up maybe in the FNAC or excision biopsy. So you may need to work out, and then the treatment protocol has to be specific. Like if it is tubercular, anti-tubercular treatment may require. If it is neoplastic like Hopkins, then a specific treatment may be required in the current situation. A few of the conditions there would be where there is a non-specific, simple chronic inflammatory conditions, non-specific inflammatory conditions also can present with the lymph node severity. Many times simply reactive pathologies also can present with the lymph node conditions. In such conditions, in non-specific conditions, I would be treating those conditions with the Triphala Gokulam Mrityunjaya Namatarishta. Otherwise, without that, without specifying the diagnosis, without having a diagnostic workout, treating the patients of lymphatic aggregation, lymphatic swellings would be harmful, could be quite dangerous. So we need to consider this part as a significant issue in the current situation. Then Karkaruka, Yervaruka, Narikela, Priyala, Panchangula, Bijapchuli, Vatarpudam, Kshira, Gazambusiddhi, Gushne, Sateli, Upanahayeto, Puriyach Mukhan, Upanahanani, Siddhish, Mamsi, Athavesavarehi, Svedam Vidadyat, Kushalastanadia, Shukena, Raktam, Buksho, Harecha, Vatagna Nirivuha Payo, Amla Bhage, Siddham Shataksham, Trivudam Vipetva. In case of Vataja Arbuda, and again with the Nidana, we have discussed about that issue, Arbuda and Granthi, their differences and so on. The arbuda are non-suppurative conditions which do not suppurate, whereas Granthi may become suppurative. So, to decide about arbuda and Granthi, you have to wait till and see confirmed like whether it suppurates or not according to Sushruta. But in the present day situation, you have a better advantage in a tool like histopathology. If you take the tissue and then study under the microscope, we can make out whether it is a inflammatory or neoplastic. And if it is neoplastic, then the protocol of treating the neoplastic conditions are different, which I will come to that at the end, what I do, the strategy of dealing with that. But Sushruta's suggestion would be like Upanahana and then Svedana and Raktamokshana, or that's the treatment in case of Vataja Arbuda. In case of Pittaja Arbuda, again, Svedapanahan, Vyavasthakaryaha, Pittarbude, Kaya Virecharancha, Yuhirishya, Gudumbarashwa, Shaka Goji, Patrehi, Prisham, Chaudri, Pralimpeta, Srakshni Krati, Sarjarsa, Priyangu, Patanga, Rodha, Anjana, Yastika, Fehi, Visra Veta, Aragvada, Goj, Somaha, Shama, Yodja, Kusalena Lepe, Shama, Girihwa, Anjanaki, Raseshu, Drakshara, Sapalika, Rasecha, Grisam Pibet, Klitakasam Prasiddam, Pittar, Budi, Jatari, Jantu. In case of Pittaja Arbuda, Mrudu Sweda has to be done, and then Virechana is other suggested treatment, and the local application of the Sarjara Satriyanga etc. has to be tried, or internal administration of the Klitaka Grita is given. Shuddhasti Jantoho Kapaje Arbudetu Rakte Avasikte Tato Arbudam Dravyani Yanti Udhum Adhashta Doshan Haranti Kalki Krihi Ebrishata. Kapota Paravata Bidbi Mishrehi, Sakansi Nilehi, Shukalangalehi, Mutristu Kakadani Mura Mishrehi, Sharap Pradigdihi, Athava Pradishyata. In case of Kapala Arbuda, local application Raktamokshana and then application of a Tikshna Lepa, different lepas, where the contents could be many animal products like the feces of birds, Kapota Paravata, etc. also are used. Some odd sort of combinations are used in the treatment of Kapala Arbuda. Then in case of Mesoja Arbuda, Nishpava Pinyaka Kulatha Kalkehi, Mansat Pragadehi, Dasimastu Yuktehi, Lepam Vidadhyata Kramayo, Yatha Atra Murchanti Munchanti, Athava Atha Makshikashta, Alpavashiste, Krimi Bhakshiteja Likhe, Tato Agnim Vidadhita Pashchata, Yadalpamulam Traputam Sisa Patti, Samabeshchetara, Ayasirva, Sharagni Shastrani, Asakrit Vidadhyata, Pranan Ahimsan Bishaga Pramataha. आस्फोत जाति करवीरपुत्रैः कषायम् इष्टं रसोसनार्थं शुद्धे च तैलं विदुरितभाङ्गे विडङ्गपाठा त्रिफला विपक्वं यदृच्छया च वपुगतानि पाकं पाकक्रमेण पचरेत् विधिज्ञः. In case of the Mesoja Arbuda, the primary treatment is it has to be removed. But a surgical removal, when it is not possible, a complete removal in a single sitting is not possible, then there could be a procedure of a partial reduction of size. In the present day situation, if there is a tumor pathology and if it is not surgically removable, amenable to surgery in a single sitting, you have many options. One of the option is reduction of the size by chemotherapy. The other option is a stage by stage resection, partial resection. You remove the tumor to the extent possible, leave the remaining area so that the patient's life condition, general condition can improve, and followed by some other supportive therapy. If possible, you may go for the excision later. So stage by stage excisions, partial resection, reduction of the size by the chemotherapy or other supportive therapies is one of the options which are suggested in the present day situation as a surgical tool in those conditions which are inoperable. Sushruta has had used a different sort of a natural phenomena for that the partial reduction, and that's about injection of the maggots. You, in a case of a massive tumor of Kapha-Javitra or Meso-Javitra type lesion, then it has to be, the maggots have to be induced by applying the substances like Nishpava, Pinyak, etc. The different sorts of the food substances are applied over the area so that there will be the maggot formation. And once the maggots have removed a part of the tumor or part of that mass, then the remaining mass has to be treated with the removed with either Kshara, Agni, or maybe the surgical removal depending upon the condition, ensuring that the patient's life is maintained, the vitality is maintained. So this is a very important surgical principle. When a single sitting surgery is not possible, having a protocol of reduction of the size, stage by stage resection, is one of the important surgical tools, and that message is given by Sushruta in this context. Though the exact methods which we may use now may be different from what Sushruta has done. And then, of course, once it is removed, then the treatment has to be with the Bhangi, Vedanga, Taila, etc. to prevent the these next recurrences, right? Or Medorbuda, Swinnam Matho Vidarya Vishadya Sibet Gadraktam Asho, Tato Haridra Grihadhuma Rudra Pratanga Tirnehi Samanashilalehi, Vranam Pratigrahe Nupragadehi Karanja Tailam Vidhita Shuddhe, Sashesha Drishani Io Arbudani Karoti, Sasyashupunar Bhavanti, Tasmat Asheshani Samudharetu, Hanihu Sasheshani Yathahi Vanihi. In Medorbuda, if it is curable or if it can be excised, then after Svedana, you have to remove that whole of the lesion, excision has to be done, and then the wound has to be treated. One of the important principles in the case of arbuda treatment is you have to remove the arbuda completely. This is very absolutely true. In case of any neoplastic pathology where the lesion is irreversible, a complete cure is possible only when you have removed the whole tumor in entirety. In the present days protocol of oncological surgery, we always give an attention to the border of the lesion under microscope to ensure whether the lesion is completely removed or not. If the border is free, then the next follow-up treatment doesn't require the same intensity of the palliative treatment like chemotherapy. If the border is not clear, then you may have to have more rigorous treatment. Now, that issue is mentioned by Sushruta. Important is Sushruta knew about this. Like a complete removal is a vital issue in case of the treatment of arbuda. If even a small piece of or small single cell of the tumor is left over, there is a possibility of recurrence, and Sushruta compares it to a fire. A small small entity of the fire can result in a huge fire if it is not treated. Now, though I don't always say that arbuda is a tumor, but because it is quite commonly expected, like the treatment is about the arbuda and malignancy. In the present day situation, when we treat the malignancy, it's a important thing, like you need to be careful, or you have to be relevant in the current situation where you have advanced oncological treatment and many of the conditions are curable or some of them are better manageable. So keeping that in mind, to ensure that the safety of the patient and the advantages of the patient has to be maintained, that's what we call as the principle of magnanimity has to be maintained in the practice. My strategy, I underline this, my strategy of dealing with the neoplasm. Of course, when I say this, I do not mean that all arbudas are neoplasms and so on, that kind of an academic discussion, keeping it apart. From the practical clinical point of view, when we treat the cases of the neoplastic conditions, keeping that idea of the safety of the patient and advantages of the current science keeping as such, I would be treating my patients along on these lines, and this is what I would just say. Like the type of variety of the patients whom I would see, like would be many of the large number of patients. Now, this is data collected from my practice in the past few years, 2006 to 22, in the few years, like, and number of malignant neoplastic conditions of different category. Now it includes all sorts of the categories, not only single type of the malignancy. In such conditions, the patients who come at a terminally ill condition where everything is done and there is no hope left over in the contemporary science, that number is quite huge. It's a quite 8,000. That's from out of around 12,000 patients, like. And dropouts from therapy, those who have started with the chemotherapy or radiation, but they are not able to sustain due to any reasons, and they want to have an ayurvedic alternative. Such patients is again another group of these patients, something around 1,500. And those patients who are undergoing chemotherapy, they want to continue, but they want to have some backup with ayurvedic treatment, prefer an ayurvedic treatment. That comes under another category of the patients. Patients who are diagnosed with malignancy, but before going for chemotherapy, they are not willing to go for chemotherapy. They want to have ayurvedic treatment. That's another group of the patients. And some of the patients, they might have already been diagnosed and they want to have a second opinion, like whether chemotherapy is better or ayurvedic treatment is better, and your choice, like that's one case. And a good number of patients may be diagnosed by me based upon the clinical presentation for the first time. So the categories of the patients are this, and my strategies in these patients would be considering this would be like in the patients who have that terminal ill conditions where there is a low expectation, all the effort would be to add life to the days as far as possible, make the condition better, whatever the treatment required depending upon the patient's symptoms, like it could be IV fluids, it could be nourishment, it could be medicines like Rasayana Dravyas, Arogya, Kumaryas, Avagnitin, whatever that. So I don't suggest any specific protocol there, and treatment of the malignancy is not the target. The target is to ensure that the patient is having a better quality of life to the level he is able to live, and that the selection of the drugs would be based upon the dosha lakshana seen in the patient. Now, in the patients who have dropout of therapy, again, my advice would be judicious advice. If there is a need for, if the continuation of the treatment protocol of current science gives better results, I would always suggest the patient better to continue. But if the condition otherwise is not going to help, so to suggest this, you have to be aware of the limitations and the advantages of the current protocol of the treatment, and only when you have that kind of a background, you can advise the patient correctly. And if the patient doesn't prefer, then the treatment again would be dosha lakshana based approach. Like if the patient has vata lakshanas, I will bring, depending upon the sort of, maybe we may call it as a symptomatic treatment. There is no such standard treatment given for malignancy by as such. In the other two categories where the patient is undergoing this therapy, but he wants to have a backup, I will be focusing on Dhartogni, and my preference will be Arogyavardhini Kumari Asava and Kanchanara Guggulu. Kanchanara Guggulu as a general treatment, Arogyavardhini Kumari Asava is the usual drug which is administered along with the patient, other treatment protocol which is given, which makes the patient better, conditions would improve, and the patient's tolerance to the chemotherapy or radiation would be better. And in those patients where the patient would have a second opinion, you need to have an unbiased opinion, and I would always prefer to have an unbiased opinion based upon the latest information. There it's a very difficult task, the challenging task, because you have to know the limitations and the strengths of the current protocol of the treatment, and the advice has to be proper. So I would consider this as a very challenging task, and unless we are up to date with the current information, it's quite difficult to deal with. And the patients who are diagnosed by me, again, it's a judicious and unbiased advice. I may treat the patients or I may not treat the patients based upon that. Like if the patient has a better prognosis, on the contemporary side, then I would be referring the patient to the contemporary side. If the treatment outcome is poor there too, then the choice is given to the patient, and then we may continue the patient treatment again. There again, the treatment would be based upon the dosha lakshana. In summary, that's about how I deal with the neoplastic conditions. That's all. And then I say this, it's not that whatever I say is final. You may have a different sort of the approach, but my approach is based upon the basic principle of the clinical discipline. Then the next is about the ganda. संसेद्य गंडम पौनोत्थमादम नाट्य अनिलग्न औषध पत्रभंगैः अम्लैः समुद्रैः विविधैः पयोभिः उष्णैः सतैलैः पिषदैश्च विद्वान् विस्रावयेत् स्विन्नम् अतन्त्रितश्च शुद्धं व्रणं चापि उपनाहयेत् क्षण अतसी मूलक शिग्रु चिन्म प्रियाल पंजा अनैदैः तिलैस्तु काला अमृता शिग्रु पुनर्नव अर्क गजादि नाम करहाट पृष्ठैः करहाट कुष्ठैः एकैशिका वृक्ष कतिलोकैश्च सुराम्लपिष्टैः असकृत् प्रलिह्यात् तैलं पिबेत्य अमृतवल्लि निम्ब हंसाह्वय वृक्षक पिप्पलीभिः सिद्धं बलाभ्यां सदैवदारोहिताय नित्यं गलगण्डरोगे. In case of the galaganda of Vataja variety, the Swedana is done as one of the option of the treatment, and then the lep and upanaha is done, and then internal administration of the drugs are preferred. Now, if you consider the present day situation as thyroiditis, as Vataja Galaganda, the typical features of the Vataja Galaganda are the same of thyroiditis, either autoimmune or infective. The typical features are Todanantah, Krishna Siravanantah, Krishna Aruna Va Pavanatmagastu, मेदोन्मिलश्च उपचितश्च कालात् भवेत् अतिस्निग्धतरोः रुजश्च पारुष्ययुक्तः चिरवृद्ध्यपाकः यदच्छया पाकमियात् कदाचित् वैरस्यं मास्यस्य जन्तोः भवेत् तथा तालुकलप्रशोषः. Mainly we come across two varieties of the thyroiditis, autoimmune or infective, and in that condition the one of the important issue is about the euthyroid status. See, in majority of the patients of thyroiditis, initially they may become either hypo or hyperthyroid, but later, after a few days, they become normal. The thyroid either become normal, or some of the patients may continue to be hypothyroid. Now, this differentiation is quite important, and this part I think I have referred to in case of the Nidana, like Hashimoto's thyroiditis or Riedl's thyroiditis. Hashimoto's thyroiditis, in due course of time, the patient may remain hypothyroid, whereas Riedl's patient may become normal, euthyroid. Infective conditions also, the patient has a risk of developing hypothyroid conditions in due course of time. So, monitoring of that thyroid function is necessary, and ensure that the patient is in a euthyroid status. As long as required, you may require the supplementation of the thyroxine or maybe antithyroid drugs depending on status, but this has to be very judicious, it has to be very careful. Then once the patient has come out of this level, or maybe during that status where the patient may have a thyroid abnormality even, my preference of drugs would be Kanchanara, Mrityunjaya, Amphotericin. I may not prefer that local application of the lep in such conditions, or to promote for the suppurative changes as such. Then Kafaja arbuda, Kafaja galaganda, Swedopanahi Kapsambhavantu Samseti Visravanamem Kuryatam, Tato Ajagandha, Ati Vishalya, Vishanika Kusha Shukakpayabihi, Alasha Bhasmodaka Peshidabihi, Dikshat Sakunjabihi, Ashitalabihi, Dashanta Sankehi, Lavaneshiyuktam, Tailam Pipet Magadikadi Siddham, Prachaddan Murtha Viretananja, Dhumasha Viretaniko Hitasto, Pakakramo Api, Sada Bireha, Vaidian Pakam, the Teo Kathanchita. In case of Kapaja Galaganda, the treatment has to be local application, Vamana or Shiro Virejana or Vaidejanika Dhuma has to be done, and to ensure that there is no possibility of separation. If it becomes separated, then the treatment would be as usual of separation. In drainage is the treatment. Katatrik Saudrayuta Samudraha Bhakshaha Yavanani Rasashta Maudgaha Sasunda Vera Sapatola Limba Hitai Deya Galaganda Roge. The drugs like Tikatu with Gomudra or the Mudgarasa has to be given, or Shungabera Shumti has to be given as a preventive for the Galaganda. Medasamukte in Medaja Galaganda, Yathopadishtam Vidhet Siram Snigdataroha Narasya, Shama, Sudha, Loha Purishidanti Rasanjaneshta Hitapradeha, Mutrenava Alodya Hitaya Saram Pratat Pibet Sala Mahiruhana, शस्त्रेण वा आपाट्य विलार्य चैनं मेधस्समुद्धृत्य हिताय सीवेत् मज्जा आद्य मेदो मधुविर्बहेद्वा दग्धे च सर्पिः मधुचापचार्यं काशीस दुःखे च ततो अत्र देये चूर्णीकृते रोचनया समेते तैलयञ्च अभ्यद्य हिताय दद्यात् सारोद्भवं गोमयेत्यस्मा हितश्च नित्यं त्रिफलाकषायो गाढश्च बन्धो यवभोजनञ्च. In case of Medo Jagalaganda, again Siravyadha is the first line of the treatment, and then internal administration of the different preparations prepared with the Gomutra, or then surgical excision, surgical removal of the lesion, surgical excision is suggested. Now, if you consider that Medoja or the Kapale Galaganda, both of them into a goiter and iodine deficiency goiter, or maybe the other sorts of the goiters, different type of the goiters, the current protocol of the treatment would be there is a very limited utility of medical treatment, and the limited medical treatment would be Kanjanara Arogyavardhini Kumaryasana. Surgical treatment, whether it is needed or not, that depends upon the histopathological appearance. So any goiter now, I would be suggesting the patient to undergo FNAC to confirm. Iodine deficiency goiter may not require a surgical treatment. Supplementation of the iodine, of course, is one of the important issue, and now iodine need not be supplemented as a separate substance, because as a rule you have iodinated salt in the market, and hence that's not necessary. But the internal administration of the drug like Kanchana, Arogyavardhini, Kumaryasana may help in reducing the symptoms, but I don't say that it can cure. And whether surgery is needed or not, that depends upon the histopathological evidence. I will not go into the detail like in which type of those conditions have required this. We may discuss this issue when we discuss thyroid diseases separately in the other context. With this, we conclude this chapter with the Susasamhitam Chikitsastane Granthi Apaji Arbuda Galaganda Chikitsa Nama Ashtadashodhyaya. If there are any questions, I will try to answer, and then there is one question. Can you share some of the success clinical cases of CA patients? Of course, and there are many. I don't say one or two. Success in the sense to decide whether it is a success or not, it depends upon comparison to what the contemporary science would give. If we can give a better result than the contemporary, then we can consider success. I don't say that a malignancy can be cured completely. So that's the idea, and to give one or two examples, of course, I will be maybe one example would be one of that patient who was treated in somewhere in 2004 and 2005. 2004. One old lady who was treated who was diagnosed as a stomal tumor in KMC Manipal, and she had developed a complete intestinal obstruction features. And then of course, at the last stage, the patient came to our hospital with practically no hope. And during the clinical examination of the patient, what I found was that tumor, a palpable mass, if it is twisted, the patient would be able to pass the flatus, though the patient was on this continuous administration of IV fluids. Patient was not ready for surgery at that moment, but I insisted on the patient and opened the abdomen. Laparotomy was done. Tumor was not excised. I didn't remove the tumor because the excision of the tumor would result in enterostomy, which the patient was not ready. So I just kept the tumor outside the peritoneum. Extra peritonization was done, a unique form of surgery which is never done anywhere, and so that the tumor would not again twist and then produce the obstruction. Patient was able to take food orally, and gave Kanchana Arogyavardhini continuously, and the patient recovered very well. For about 4 or 5 years, the patient had survived without any complication. Later on, the patient died due to some other complication like a cerebrovascular accident. In between, we had to give 2 or 3 blood transfusions to build up the patient. Throughout the year, those durations, patient was taking Kanchana Arogyavardhini. In 2007, when we had organized a conference on treatment of malignancy, that patient was presented, live presentation on the stage, and it was quite impressive. So maybe one of that. Of course, there are plenty of such issues which may not be within the limit. So just because he has asked for Rajat has asked for one example. I have given one example, and so on. There are plenty of that where we can give a better treatment, maybe at a lesser cost. That's what I always claim. Then using Arogya Arjun Kumari also is Dhatvagni. See, my target is in case of malignancy, it's Dhatvagni which is impaired, and hence to target Dhatvagni, one of the tools which we have would be Arogya Arjun Kumari Asava. That's what I would prefer. Then how to decide at what stage CA can manage through our medications and what stage I. So this question, of course, you have to have a very clear idea of the limitations of the current oncology. Only when you know exactly like in which of the conditions the contemporary oncology gives a better treatment or not, or outcome of that has to be. So you need to be in constant touch, constant study. Regularly you have to look at the statistical data of the outcome of the specific neoplastic conditions, and based upon that you can decide in which of the conditions the contemporary science can give a better treatment or not, what could be the outcome. And once we educate the patient about this issue, like the limitations and outcome of the contemporary science, then the decision can be taken. So that's what I said, it's a very difficult task. I have mentioned that part like as a very difficult task to give a correct advice. So you need to be constantly updated about the contemporary outcome as such. So I would always say that if you have a good Ayurvedic doctor, you should be a better modern scientist. You have to more modern than a modern doctor. Then only a Ayurvedic practice can be done. So this is one of a very sensitive issue as such. So I think I can't answer that question better than that. Okay, right. There are no more questions. With that, we will conclude.